good afternoon to all. Welcome to our ninth session. It's been a long time. We suffered all the sessions due to COVID emergencies. Thank you all for joining back. So today we are having a session on palliative care and non-cancerous illness, and it will be taken by Dr. Pankaj. So what is Sunil sir?
Good afternoon. Today we are having a very important session because many palliative care centers focus the palliative care mainly on cancers. But there are many other centers who also see patients with non-cancer illness who require palliative care. So Dr. Pankaj, who is an assistant professor in pain and palliative medicine at KMC, Manipal, will be talking about non-cancer palliative care. And he has done his MD in palliative medicine from Tata Memorial Hospital. He has been working in palliative care for a couple of years. Welcome, Pankaj, and it's over to you.
Thank you so much, sir. So good to see you here again. So many days.
Pankaj, one thing is that the participants are PG students from Physiatry Department of Trivandrum Medical College.
Physical Medicine Department.
Yeah, Physical Medicine Department. Yeah.
Okay, good. Yeah, so it will be good to see the audience. Means recently our hospital has started Department of Physical Medicine and Rehabilitations, and I can see a lot of same scope of integrated palliative medicine and rehabilitative services, especially in non-cancer illness. So it will be interesting to interact with you. Okay, so today we will be talking about palliative care in non-cancer illnesses. So as Dr. Sunil told, most of the palliative care is dedicated only in cancer settings, but nowadays a lot of centers are involving patients with other illnesses also. So recently there was a change in palliative care definitions. Previously we used to see the definition given by the WHO, but recently various associations has come out with a new definition. So they say like the palliative care is holistic care for patients with all ages with serious health related suffering, and it can be due to any severe illness. It is particularly, it has role when the patient is near end of life. I hope this definition of redefinition of palliative care will help in widening our scope of multiple diseases. So what all are the diseases where palliative care can be involved? Before that, this is a common trajectory that we usually see. So there are multiple kind of illnesses, how it progresses and how the patients reaches toward their end of life care. So if you can see the red dot, the red dotted line here, can you see my cursor also? No?
Yes, Pankaj, we can see.
Yes. Okay. So this red line, it indicates mostly the cancer illness or those terminal illness. It means patients have good functional ability throughout the illness, but all of the sudden when the patients reaches the advanced illness or to the terminal cancer, the functional ability of the patients, it reduces quite significantly over a little span of time. While in other illnesses like in CKDs, in COPDs, in many neurological diseases like Parkinson's, dementia, this is not the condition. So in like COPD or CKD, patients functionality decreases gradually. But there may be some episodes where the patients may develop some infection and or some exacerbation of the illness, where the sudden deterioration in his physical health occurs. But they come out of that. So they may come out of the exacerbation of COPD or advanced heart failure, and again they will have near normal activity in their functionality. But this gradually decreases, and this goes on multiple times. So what challenge it occur means, you see there is a dip. So at the time of dip, we do not know like whether this patients will uh, uh, means is near their end of life, or whether the patient will improve out of this. That's the difficulty with patients with non-cancer illness. Like their trajectory is not uniform. We don't know how much time they have for the survival. Other is the green line is indicates the frailty or the patients with dementia. So over the time, the continuously their functionality decreases. So how we can identify such patients? So if you can see this yellow arrow, it shows like early end of life identification. So it is very important to identify those patients whom palliative care input can be involved. So the common approach is like whenever the patients fell sick or when they come to the hospital, that time we can involve the palliative care team, and then they can identify the needs of palliative care in such patients. So usually during the transition period, early transition period, if we can involve palliative care, that would be the right. So, what are the common illnesses in which palliative care can be given in non-oncological illness? So, like some lung diseases, common example is COPD, interstitial lung diseases, a lot of diseases because of uh, their birth profile. Patients with heart failure, especially end-stage heart failure, patients may benefit from palliative care. A lot of patients with CKD on dialysis, on those who are not yet started on the dialysis, they may benefit from palliative care. We commonly see patients with neurological diseases since I think from the inception of palliative care, people with neurological diseases have benefited from palliative care. So these patients are especially like dementia, advanced dementia, patients with stroke or traumatic diseases like road traffic accident or severe brain injuries. Those patients may require long-term care. You know, you all must see in these patients with neurological diseases who require long-term rehabilitations, but integrated palliative care approaches can also be involved. There is a role of palliative care in infectious diseases, especially the end stage AIDS complex disease, multi-drug resistant tuberculosis, many patients with post-TB sequels who are breathless, chronic breathless, or they are chronic malnourished, or many life-threatening infections, like commonly we are seeing now in COVID disease. So in European countries, we have seen that there was a role of palliative care in such life-threatening infections also. There are some new model of palliative care that is coming up in like humanitarian crisis situations. The palliative care integration in ICUs, those patients who are in ICU for long term, or those patients whose chances of survival are not very good. In those situations, how palliative care can help the patient and family, and especially and also palliative care from the emergency department itself. So we will discuss about all these things in little detail. So before that, we will go to how to identify. So there is GSF criteria, that is gold standard framework. They have developed a guideline, that is proactive identification guideline, on how to identify these patients. So it is for cancer also and non-cancer also. So basically there are three steps. So first step is to identify those patients how whom palliative care may be needed, or what are their needs. Then assess them, what are their current needs and what are their future needs. And then plan them. So plan how we can improve their quality of life, and we can provide them good end of life care. So in identification, and that is the most important part, there are again three steps. So in the step one, we ask the surprise question. So surprise question, what is on the surprise question? It's a common question, like we ask ourselves or the treating doctor, whether will you be surprised if the person were to die in next few months, few days, few weeks, few months, or in a year. And so if the doctor says that no, I won't be surprised, then that patient is eligible, or that patient is for palliative care, appropriate for palliative care. If if doctor says yes, I will be surprised, then there may be some general indicator that of declining or increasing needs, or you may assist later, maybe 1 month later, or in the next appointment, again with the surprising questions with the treating physician. So now what are the general indicators of declining health of the patient or increasing needs? So first is like a general physical decline or increasing dependence on other, or those patients they need more support. So especially patients with elderly who are frail, or who have comorbidities. They usually say like we are now more dependent on other, and their main worry is like they do not want to be dependent on other, or they other indicator is unplanned hospital admissions, like maybe multiple admissions in last 6 months or last 1 year. Is the advanced disease is associated with complex symptom burden. There may be presence of significant multiple comorbidities that is associating or deteriorating the health of patient. Decreasing activity, like performance status of the patient, or those patients who are on the bed for most of their time. Uh, Other indicator is like that the treatment is not helping the patients, or it is not able to reverse the disease. Uh, the most important, or I think the single most important criteria is like patient's choice, the patient's autonomy, that they do not want uh, further active care, and they want to focus mainly on the quality of life. So if a patient chooses for quality of life, the palliative care should be integrated in their treatment. Other some criteria are like there is progressive weight loss despite the best correction, or maybe some events that can change the course of illness. And one biochemical criteria, that is single most indicator of mortality of any disease, is serum albumin level also. So if it is less than 2.5 gram per deciliter, then is also indicator of it's a poor outcome indicator of most of the chronic illnesses. Then we will come to disease-specific indicators. So there are some disease-specific indicators. I will go one by one to all the diseases. Um, for the heart diseases, the patients with heart failure, whom palliative care can be helpful, are like those whom sulfurized cushion is applicable. Those patients who are very breathless, even with minimal exacerbation, or even at rest they are breathless. Those patients are candidates for palliative care. Those patients who required multiple admissions, so here there is like 3 admissions in last 6 months, or even a single admissions in patients who are more than 75 years age. uh, Difficult ongoing physical or psychological symptoms despite the therapies, and also on the biochemical indicators, if there is persistent hyponatremia that we are not able to correct. So this is how we can identify most of the patients. So there is criteria for COPD, like multiple hospital admissions, or many times like multiple ICU admissions, because patients with COPD, they may get admitted multiple times. So if those patients has fast ICU admission, or at least 3 ward admissions in last 1 year, then that patients may be considered for palliative care. Those patients with very severe breathlessness. So in heart diseases, we take NYHA scale. Here in lung diseases or pulmonary diseases, we take modified MRC grading. So if it is 4 or 5, then those patients are eligible for palliative care. Those patients with very severe COPD, or those who are on long-term oxygen therapies, those patients requiring NID or BiPAP even at home, or there are score pulmonary, or they fail to thrive, those active patients. All of them are candidate for palliative care. So here in our hospital, we have seen means after integrating palliative care with a pulmonologist. So they have found a lot benefit in those patients who have chronic breathlessness syndrome, uh, with inputs from palliative care. We will come later what inputs can be given in such diseases, such like COPD. Then CKD patients. So CKD patients, you have seen like our country is the capital of diabetes and hypertension, and that's why we are seeing a lot of patients who are coming up with CKD, or those who are on dialysis. So it is important to identify CKD patients also. So again, if there are repeated unplanned admissions, or those patients who are not tolerating dialysis, or they are requiring multiple change in the modalities also. Again, the most important decision, that is autonomy of the patient, is like choosing no dialysis option, or renal supportive care as the option. So those patients should be given option of palliative care. Again, these patients have a lot of symptoms, maybe physical or psychological symptoms, and that is not responded to the specific treatments. Or those patients who are not on dialysis but are very symptomatic. So palliative care for the symptoms can be useful. Then the liver disease in those patients who are not candidate for transplant, or their cirrhosis or liver damage is quite significant in those patients. Palliative care inputs may be helpful. There is a lot of role of, as I said, of palliative care in neurological diseases. And so, these patients, how do we identify such patients? So, again, if there is progressive deterioration in their health, and despite the best treatment, then next is symptoms. Those are very complex and they are difficult to control. Like a lot of patients with Parkinsonism or with a stroke, they develop the rigidity, and that is many times very difficult for the patient to manage, and they have a lot of pain. So in such conditions, palliative care integrations may help. I'm sure you means as PMR physicians, you must see a lot of patients with neurological diseases with such problems, and you must be managing those patients. So, like swallowing problem, dysplasia that is causing multiple aspiration problem, multiple sepsis, patients who communication is difficult. In patients with Parkinsonism, if the treatment of Parkinsonism is not very effective, those patients who are dependent on other for activities of daily living, or whose mobility is a problem, there is a lot of involuntary movements in those patients. The palliative care inputs may be helpful. We see nowadays with motor neuron diseases also, those patients who general physical status is declining very rapidly, or those who are finding it difficult for their normal cognitive abilities. In such cases, regular home-based palliative care is recommended. Then comes the dementia. So dementia, usually we have some skills to identify what stage of dementia they have. So very commonly used one is the FAST, that is a functional assessment staging. So if it comes as moderate or severe stage of dementia, then those patients are eligible for palliative care. Uh, then there may be some other triggers that can indicate like this patient is in the severe stage. So, like those who are not able to walk without assistance, or those who are developed incontinence, they are not able to do the normal communications, or they are more dependent on others. Uh, those may be considered for uh, palliative care. Plus, there may be some other indicators like persistent weight loss, urinary tract infections, and, grade 3 or grade 4 pressure source. Uh, and they have an appetite problem or multiple aspiration needs. In stroke patients, again, if we can use some validated scales which shows the severity of a stroke, or those patients who are in the long term, like a permanent vegetative state, or reduced consciousness for long term. Uh, in those patients, palliative care can be involved. Uh, mm, there are those patients who are developing complications, frequent complications because of the stroke, can also be listed. Uh, the patients with post-stroke dementia. There are some other indicators also, like very old age patients with other diseases like heart disease or hyperglycemia dementia, or renal diseases can also be a candidate for stroke. Then this I forgot to write. The in patients with frailty, those patients who are frail without any illnesses also can also be candidate for palliative care. So those people who have either deteriorating performance status, or those so feel more weak. Those patients who have decreased slow walking or means even they cannot stand up from the chair. So these are some of the criteria how you can identify the frail patients for palliative care. So I will go back to the palliative care here. We will what are the more main approaches for palliative care in such patients. So it is nothing different from cancer patients. So it comes back to the symptom management. So we have to focus on very aggressive symptom management in such patients. For symptom management, again, we have to proactively identify those symptoms. So we routinely use some checklist to identify those symptoms, and checklists it can be modified to individual diseases. So like for cancer we use ESS, but for kidney diseases we have to use a renal version of ESS. So for each diseases you can easily find out the checklist for those problems. And even the symptom management in such patients may be the approach may be different in different diseases. Then comes the psychosocial parts, psychosocial support in such patients, because these patients are ill for quite a long time, and there must be some associated psychological distress in the patients and also in the family members. A lot of studies says like patients, family member or caregiver who are seeing such patients for a long term, they are often found to be depressed. So proactively we have to ask the family members. Third thing comes as communication. So communication about the disease, about the prognosis, and very important is advanced care planning in such patients. Um, it may be very difficult to identify those patients who are near the end of life care, but if we talk from the beginning about sensitize the patients about advanced care planning, that may be very helpful. And if the patient has reached to the terminal stage or actively in the end of life care phase, end of life phase, then care for the dying patients, appropriate care at that time has to be given. So these are the main four pillars that we talk about in non-oncological illnesses also. And I think it is not different from cancer illness. Only thing is the challenges may be different. Means our strategy we have to modify. So I will go into little details of two diseases here because we don't have much time. One is kidney and chronic kidney diseases palliative care. I routinely see these patients because I see the renal palliative care here, and the other is HIV that we routinely see. So if you can see this graph, the 5-year survival rate of the dialysis patient is around 50 to 60% only. So means what does it mean? Like only 5%, half of the patients survive for 5 years, and that is almost similar to most of the leukemias or myelomas or colorectal cancers. So yeah, so a lot of patients dies on the long-term dialysis also. What is the treatment for such patients on CKD is either the transplantation or the dialysis or the means conservative care. So those patients who receive the transplantations also, they also may be in the candidate for conservative care. Those patients who are on dialysis may need conservative care for some symptoms or some psychological issues. And third category of patients may be those who choose not to undergo the transplant or dialysis. So there was a study in which they tried to find out like uh, how many the time gained because of dialysis, how did they utilize. So they have found like 80% of their days where those patients survived, they have to spend it on the dialysis. And this is a very important finding, because people think like they are surviving on the dialysis, but they have to spend quite a lot of days on the dialysis and also the resources. So I mean to say, like there can be an option in some patients whom dialysis may not be needed. There's another study which says that there is some something that may not improve with dialysis or even worsen with dialysis, like bodily pain or general health perception, someone their side, social their role in the society, or their emotional well-being. These things worsened on even those who are on dialysis. While when they compared it with those who are not in the dialysis, they felt like their pain was not worsened, or their perception toward their general health was not worsened. There is very important guideline on renal supportive care, that is by the CADI group. So here a lot of nephrologists and palliative care physicians came together and put the guidelines for renal supportive care. If you are seeing any patients for renal palliative care, this is the must to read guideline. It has given like what are the evidences for multiple for many interventions for individual symptoms. It has also given how to assess different symptoms and what are their recommendations, how to estimate the prognosis in such patients, and how to identify patients for advanced care planning. Then this is another guideline by the nephrologists only, so these are by the Renal Physician Association, where they have given guidelines on shared decision making and when to initiate the withdrawal from the dialysis. Here, commonly in our country, we see the patients are continued on the dialysis till the very end. So even the patients who dies the same day also, most of the CKD patients received the dialysis. There was nephrologists find it very difficult to withdraw from the dialysis because they don't know when to initiate the withdrawal from the dialysis. Mm. So these are the some of the approach or the sequence how to consider for dialysis withdrawal. So like identify these patients, discuss the quality of life, and discuss the possible how we can palliate those symptoms. We have to clarify the option of dialysis withdrawal with the family member and website. And then we have to reassure them like we will adequately control the symptoms and we will ensure that peaceful death. Uh, Very importantly, like those patients may be on the dialysis from 5 years, 10 years, and their nephrologist might be telling them that like dialysis is only the treatment. So we have to give them the time for the discussion among the family member with the patients. And uh, uh, if they come up with the advanced care planning, we have to provide the assurance if needed. This decision can be reversible. This is the step ladder that is modified for patients who are with CKD. So some of those drugs that is safe for the kidney can be used, and those patients who require some adjuvants also, the safe adjuvants can be given. Here I want to add also, like those patients who pain is difficult to treat or where opioids are not available. In the patients with very advanced CKD, can also be can also be given in the NSAIDs also, especially those patients whom the renal preserve, what we call it, the nephrons are not there at all to cause the renal toxicity. So again, we have to go by the step ladder for these patients. Then about the palliative care in HIV and AIDS. So how to identify those patients where we can call it as a terminal illness in HIV. So whom the CD4 counts are very low or viral load is very, very high. Those patients who are with CNS lymphoma or Western disease or Mycobacterium avium related complex, or maybe there is leukoencephalopathy, maybe associated with systemic lymphoma, renal failure, or advanced disease infections are uh, those patients we certify it as terminal illness. Uh, what is the need for palliative care? So we have found like HIV is associated with lot of physical symptoms, and these symptoms, if it is left untreated, that may lead to poor adherence to the HART, where very poor quality of life, patients' demoralization, and like increased disease complications. So nowadays, like HIV is not considered as like life-limiting illness. Most of the patients with HIV almost have a very good lifespan. So, but if their adherence is poor, their quality of life may be very poor. So, involving palliative care may get these benefits. Also, apart from the physical symptoms, there are a lot of stigma associated with disease, and that can lead to a lot of psychological symptoms. So these were the again the same approach for of palliative care. Again, four domains like clinical care, psycho, social, and spiritual care. Those patients. So in the clinical care, like and there may be those patients who are asymptomatic. So in those patients, we can provide the routine clinical monitoring, those services to prevent further infections, or um, approach to treat those infections or prevent those infections, safe water and nutrition, and counseling for the family members or others for prevention from HIV. Then comes the symptomatic patients who are symptomatic. So those patients, adequate pain control. These patients suffers a lot with the neurological pain. Uh, so a good pain control can be given. And third comes the end of life care. So appropriate end of life care has to be given in such patients. So if we see the pain in HIV/AIDS, it can be because of as such the HIV infections, maybe because of the treatment, like the procedures, or because of ARTs that can cause neuropathy or myopathy, pancreatitis, and because of the debilitating conditions like multiple pressure sores, constipations because of the disease and treatment. These on can lead to complex pain syndrome. Uh, they have very common fatigue, so like fatigue specific treatment or palliative treatment, like using appropriately the steroids or psychostimulants in these cases. Other common thing is weight loss or anorexia. So again, those medications like testosterone or progesterone that can help in reducing the weight loss in these patients can be used. So there is there is a specific treatment and the palliative approach for every symptoms. This is for dyspnea. So like those non-pharmacological and pharmacological treatment for dyspnea can be used as a palliative symptoms for the dyspnea in HIV. patients. What are common barriers in these patients? Most of the time, there is lack of knowledge among the patients and also the treating doctors also about the pain management. Many of them are reluctant to use opioids because a lot of HIV patients were drug abusers, so physicians are a bit reluctant to use these medications. And also, there are some interactions among the diseases. There is lack of access of pain specialists, concern, as I said, about the diabetes and so these are the common interactions. So we know like a lot of HIV medications are cited from P450 inhibitors, and also many of them are inducers also. And so we have to be a bit careful among those medications that is commonly used in palliative care about this. So then, so this was about palliative care in HIV/AIDS. Then we will go to palliative care in lung diseases. So as I said, that patients with severe COPD may help with palliative care interventions. Two common things that is helpful is one is patients with chronic breathlessness syndrome, chronic dyspnea syndrome. So what all we can do as like MR physicians, we must be using a lot of non-pharmacological approaches for COPD, like chest physiotherapy, a lot of positioning things, exercises for those patients. With that, there are some palliative care approach, like using appropriate doses of opioids in such patients. And relaxation exercises can help in those patients. Then comes for the neurological diseases that can benefit. So how do we identify again? Like those patients who have short onset and limited life expectancies. So this may be like severe brain injury after road traffic accidents or acute stroke, very severe stroke. Then next set of illnesses comes those who have progressive disease with degenerative mechanism. Those are usually for the very long time, like Parkinson's, motor dementia, or motor neuron diseases. So in these patients, what are the common issues? Is like again the pain can be maybe of the neuropathic pain, or maybe because of the musculoskeletal pain. There are other concerns like they are difficulty to move, or there's a cognitive impairment in these patients. There may be sensory deficit, a lot of sleep problems, abnormal movements that can cause reduced quality of life. Then these patients are find it very difficult to communicate among others. These issues related to the nutrition, like many of them doesn't want that you feeding, and they cannot feed. That comes out with multiple aspiration problems and disabilities, and again the psychosocial things. So I think I have to finish here for this thing, for the seminar. I can take some questions and that we can discuss here. Is that okay?
Yeah. Thank you, Pankaj.
So I think we can take some questions here, and then accordingly we can discuss some of the difficulties that we find it in non-cancer patients.
Okay. So, anybody has any comments on non-cancer diseases requiring palliative care, or any doubts? Yeah, Dr. Jija.
So in non-cancer states, does the palliative care start as soon as the diagnosis is made? I'm not clear about that.
Yeah. Pankaj, did you hear that?
I'm unable to hear. Can you please repeat the question?
He's asking whether palliative care should be started at the time of diagnosis in case of non-cancer illness requiring palliative care.
Yeah, means that again depends on how severe is the illness or what are the requirements at this stage. So it may be like a few things we have to identify, whether it is a non-curable illness or whether that illness has very severe suffering associated with this. So if you go back to that chart where we have seen like there is a progressive decline. So if the patient's debility or uh, the course is not very good, in those conditions, we can involve early at the time of the diagnosis itself.
Jija, it is not very clear because you know that palliative care definition, it is redefined. It can be given in case of any serious health-related suffering. So if the patient has more suffering, even though at the even if at the time of diagnosis, then we can provide palliative care. Suppose the patient has severe COPD. We have to optimize other treatments for COPD, but at the same time, patients might have other problems like psychological or social, financial, all those problems that can be, the patient can be a candidate for palliative care, but all depends on the resources available. Anybody else?
So if you don't have questions, I think we can interact here. So what are the common, what do you think, like what are the common diseases or challenges you feel uh, in your practice when you see patients with a stroke or other chronic illnesses where palliative care approach can be involved? Anyone?
Anybody? Yes. Jija, please unmute Dr. Jija. Yeah.
Usually the problem we face is continuing the care at home. That's the major problem. Then also some financial issues or some vocational issues we may not be able to completely resolve for the patient. And also IP care we cannot prolong beyond a point. So we have to send the patient home at one point. Those are the things that come to my mind right now.
Yeah. Pankaj, did you hear that?
There's some problem with voice. I think my speaker is not working well.
Yeah, so the problems that he brought out was, one is continuity of care. once the patient is discharged, the follow-up may not be easy. Then many of the patients will have financial problems. Then the third thing is they will not be able to admit the patient for long time because there will be other patients who are in the queue for getting an admission.
So yeah, that is very commonly we see here also those patients who are requiring care for a very long time, and usually those patients with like paraplegia, road traffic accidents, or stroke, they require care. I will say the long-term care, and family members, when they do not have resources, all of a sudden they will ask for a dama, that is commonly used term in the hospital, like we are not able to afford the health care at home. So what can we do at this stage? So as soon as the patient is in a ward for long-term care, uh, uh, we have to involve the family members also. Family members as the caregiver. So we have to empower the family members how to take care of the patients in physiotherapy, in the nutrition, in the changing the bed, all the nursing care, how to identify if the patient is developing any pressure ulcers or the infections. So routinely, those patients, even before shifting out of the ICUs, or when we are shifting the patients in HDUs, at that time also only we sensitize the patient, family members, like these patients will require long-term care, and the family member has to be involved in the care. So after some time, when we shift the patient at home, uh, the care can be continued, and it should not be abruptly like after a week they are abruptly asking for the discharge, and family member doesn't know anything about how to give care. Other thing is home-based care, that is home care, that we can provide at home. So routinely our nurses or doctor can assist those patients at home. Uh, that can be a solution for those patients who are economically weak, or we cannot continue care at hospital.
Anybody else?
What are the most common symptoms or most common problem that uh, you or the palliative doctor encounter in HIV patient
In which
during
patients?
HIV HIV patient?
Sorry, I
Any
am
common?
not able to hear you.
HIV patients, what are the
Yeah,
common problems? Yeah.
yeah, it's a common problem while they are in the palliative care. Any common problem that we face during the palliative care for the HIV patient?
So those patients, HIV patients, usually we talk about the physical problem. So physical problem is usually the pain. Pain maybe because of those neuropathic pain, usually the tingling pain in the lower limb, up in the hands, foot. So most commonly the neuropathic pain, or sometimes myofascial pain, especially in those patients who are not nutritionally very emaciated. Those patients also have a lot of bony or muscular pain, when they say. Other thing is fatigue. Very commonly, they say that they are very fatigued. They feel weak. Uh, in those patients, that is common symptoms.
Okay.
Patients getting recurrent infections or associated tuberculosis is there. They develop breathlessness or cough, chronic cough is in the common body. These are the common physical problem among HIV patients, especially if it is like a end stage HIV.
Okay.
Any more questions? So Pankaj, shall we go with the case presentation, or do you want to continue with your presentation?
Yeah, I think we can go to the case presentations now.
Okay. So today's patient story will be done by Dr. Rebecca, who is the senior resident in the physical medicine and rehabilitation department of Trivandrum Medical College. Dr. Rebecca, can you see the screen?
Yeah.
Okay.
Yes, I can see.
Yeah.
Can I start?
Yeah, please start.
Okay. Today's case presentation will be 18-year-old male with the diagnosis of spinal cord injury, traumatic incomplete quadriparesis with the neurological level of injury C4. Patient recovering and neurologic bowel and bladder dysfunction and grade 1 sacral pressure sore with bilateral distal end of radius fracture. Next. So the main complaints of the patient is weakness of all the four limbs and inability to pass urine for the past 3 weeks. Coming to the history of presenting illness, patient had history of fall from height on 25th April, following which he had weakness of all the limbs and there was associated loss of consciousness and there was no history of ENT bleed, seizures or vomiting. And patient was immediately brought to Casualty Medical College Trivandrum, during which he regained his consciousness and he was then admitted in ICU and breast tube and bladder was catheterized. And the next day itself, surgery of the spine was done. So soon after the surgery, patient started moving his limbs, and but then he started developing fever on post-operative day 7. But then he was managed with antibiotics, and the fall was associated with fracture distal length of radius bilateral, for which conservative treatment was done, and plaster casting was done. Next, coming to the examination, his pulse rate was 92 beats per minute, BP 130 by 80, respiratory rate 24 per minute, and he was poorly built and nourished, and he was on hard cervical collar. His power also improved during admission now, and he has improved to grade 3 plus by 5 of all the upper limbs and lower limbs, uh, uh, from grade 2 at the time of admission. So coming to the treatment, pain medications, analgesics were continued, and oral antibiotics are given when needed, and diet modifications, laxatives and suppositories, and preventive measures for pressure sore through early positional change and prevention of pulmonary complications were also done. In physiotherapy, active assisted ROM exercises of all the limbs is done. And in the investigation, CT finding, there was C5 vertebral body fracture with D5 compression fracture, for which screw fixation was done. Psychosocial aspects, the patient is staying with his parents and one elder brother, and he was working as a mechanic, and his educational level was, he studied up to class 10. So he was financially supporting his parents and was also involved in recreational and social activities before. medications. Now he's on paracetamol 500 milligram BD with acetylphenidate SOS and some ointment. So now the main concern is the patient being 18 years old young male. He used to enjoy an active social life, but now he's suddenly confined to bed and he's dependent in all the ideas, activities of daily living. And being young, male unmarried, it affects his vocational, recreational, and marital prospect. Hello.
Yes, yes, please go on.
So since he has to be taken care of, so the psychological and emotional issues of the parents is also greatly affected. So there is also one concern: how will they manage the financial crisis? So coming to the summary, 18-year-old male with weakness of all the limbs following trauma, which was associated with bowel and bladder incontinence, and also has distal end of radius fracture bilaterally. And surgery was done for the cervical spine, and the forearm fractures were managed conservatively. Now he's completely confined to bed, lacks bed mobility, dependent in all areas, and has grade 1 sacral pressure sore. And but now he has achieved some improvement in all the powers and also some sensory improvement. So mainly the discussion points, specific palliative challenges in young adult like him, and addressing the emotional and psychological concerns of the parents, and arranging the care at home in this scenario, and what can be the palliative care given to him. Thank you.
Thank you, Dr. Rebecca. So we have an 18-year-old patient who had a trauma and had C5 vertebra, fracture of C5 vertebra with a D5 compression, who had who developed weakness of all the limbs, but after surgery uh, the power is improved from grade 2 to 3, and he is living with his parents and an elder brother. He was a mechanic. Now he is bedridden.
Yes.
So uh, just a question. He has grade 3 power. So can he sit up?
Actually now his surgery was done on 26 April. So now is actually he's on hard cervical collapse. So we are just doing bedside physiotherapy. So not much. We are not yet doing much mobility or sitting up. But
yeah. So what do you think? Will he be able to sit up in the coming days?
yes, most probably there is chances of improvement and functional recovery. Chances of good functional recovery is there for this patient.
Okay.
With his age, and then improvement in the power of the limbs, regardless of the time of surgery. Within 2 weeks, he has regained one power.
Okay. So all of you have seen many young patients who sustained either paraplegia or quadriplegia. So what do you think are the specific challenges if the patient is a young adult? So I request Rebecca's friends to give inputs. Anybody? Dr. Mong?
young patient, they will probably have this kind of patient. They won't be able to continue their work or vacation or social life. So they might have depression comes up, and uh, uh, they will lose interest, and uh, mm, yeah, it will probably affect their productivity also, and their life, their religious life, their all things will be affected.
Anybody else? Pankaj?
Hello.
Yeah.
Sorry, I was disconnected. I could not hear the initial part, but I can see the slides here.
Yeah.
So as you summarized here, like it's a young male with a history of fall, and he got both motor and sensory maze. Okay. So mm, we have to discuss here like what will be the palliative challenges in these patients. No?
Yeah.
Uh, it will be, I assume, like it will be for long-term care, isn't it? Like the patient and 17 or 18 years of his age, for almost his full life, he has to be dependent on others, and at this age, mostly the parents or the siblings will take care of the patient. So the challenge would be to empower the family. How will you empower the family member to take care of the patient? So I had a very similar patient. I just saw yesterday, so I remember of that patient when I was hearing about this patient. She was around 17-year old girl and had a road traffic accident, and she was in ICU for around 3 weeks. They were from very poor economical background, and the challenge was to continue the care, as someone has asked um, uh, in the discussion. So the palliative care was involved in at that point after 2 or 3 weeks of ICU treatment. We spoke to the family member in almost for an hour. We find out what are the challenges. So the mother was not at all convinced that patient will may not recover neurologically out of this thing. Even if he recover, there may be deficits. He may not walk on his own, or uh, may not do his own things. The first and foremost challenge is like counseling of the parents or the family members. Like this event will this acute event, sudden event will lead the complete prospects of the family member. So we have to be very sensitive during the communications, and good psychological support will be needed, especially if the patient is young. Uh, and then I don't know, like how we identify depressions or anxiety in these patients who consciousness is not proper, or like who are not able to talk. Uh, mm, I'm sorry, I don't know how to identify those psychological symptoms in the patient, but definitely family members also will be required to assess, like if they are not depressed, or they are not feeling distressed. Very important is like home care in these patients. So we have to involve the physiotherapist in the team or occupational therapist in the home care team who can arrange uh, care at home, modify the settings at home. I'm sure the Pallium India does a lot of those routine visits for these patients. Mm, isn't it, Dr. Sunil? I heard about Pallium India doing those occupational therapists and changing even the home environment for such needy patients. And yeah, the next question was like arranging care at home in the lockdown scenario. So I think now with the travel restrictions coming down, the home care can be given to those patients. Only thing is like how to protect ourselves and how to protect those family members we are visiting. So again, those adequate protection equipment we have to use when we are um, going for the home visit.
Have you finished, Pankaj?
Yes, yes.
Okay, thank you. If you look at from the palliative care aspect, all the aspects of suffering would be there for this patient. From the physical point of view, his ambulation status is not proper. So he might have problems because of reduced mobility. And I don't know how much he is going to improve, whether he will be able to walk after some time, or will he be able to attain sitting balance and things like that. But from the physical point of view, if he is going to, he already developed a pressure sore. So if there are no proper caregivers, then he is going to have more problems from that physical perspective. Then from the psychological point of view, he is a young male and only 18-year-old. So he might think, okay, why did God did this to me? I have not done anything bad to anybody. So uh, that's from a spiritual point of view. And from the psychological point of view, he has problems because he lost his mobility and he is in bed, and maybe after some time he may develop clinical depression. We don't know, but it is possible that if we can motivate him by mingling with other paraplegic or quadriplegic who is leading a productive life, then that would be good for him. uh, from the social point of view, he was a mechanic and he was going out home and was earning. But now he will not be able to do much. So this is also going to negatively impact his psychological status. And he, once he is discharged to home, he may not be able to see much of the uh, friends who he was seeing previously. And uh, the thought of not earning is also something which is going to affect the patient. What we can do from a palliative care point of view is maybe help him to continue with the required physiotherapy, or it is important that we should empower the parents to take care of the patient for at least for a few months. I don't know whether he is going to attain proper mobility now, but empowering them uh, will be the first thing, most important thing, because they will be able to do the physiotherapy and helping him with the ambulation. So that's the most important thing. Uh, then we have to also teach them regarding uh, how to take care of them, not only the pressure sore, but also bladder and bowel. And the patient, because he has lost his mobility, he have psychological problems, he might be angry with his parents. Parents should take it that way only, because he has some problems and that's why he is angry with us. uh, and if he is very abnormal in the psychological status, then he has to get a counseling or psychiatry consultation. Uh, it is very difficult for the parents to come into an equation with the present status of their son, because he is only 18-year-old, and it's it will be very difficult. So we have to understand that. Uh, so we can only talk to them, and if you think that he is going to improve, then only you can tell them that okay, in a few months he is going to improve. Don't give false hopes. uh, Give only realistic hope. uh, Arranging home care in a lockdown scenario, which will be difficult in for most of the institutions, even though we were doing home care for patients under our care. um, and as you rightly pointed out, telemedicine is something which we have to explore, and we were doing that during this lockdown period. So these are some points. And he will not be able to go back into his job as a mechanic, but maybe if he is bedridden, will he be able to do something while he is sitting or even lying down? So that would give some joy to him.
In palliative care, if the patient have some like sexual problem, what usually do you used to do for the palliative care side?
Okay, so that's one aspect which I didn't talk about, but I think that's very important problem for this patient particularly. He's a young adult, we usually talk to them and ask them, do you have any problems on the sexual aspect? So according to the problems that they brought out, uh, we will help them if there are something to do with some therapies. And we also talk to the wife of the patient or husband of the patient regarding the same. And because most probably there will be some misconceptions regarding sexuality and things like that. So it is important to talk to both spouse regarding this. And they have to understand mutually. But in this patient, he's not married. So it is important to talk to them regarding these issues. That's sure. So what do you do usually?
You mean on our side?
Yeah.
Usually, like you say, we used to counsel the patient, and if the patient needs some uh, like a, device or something like that, we can give for the patient to help maintain erection, like that kind of thing. There are some devices which can use the patient to improve, and some other kind of intimacy way we can also use in this kind of thing. But
Yeah.
mainly in our place, in our department, mainly counseling is the thing that we do.
Yeah. Okay. So as you told earlier, there are different ways of making intimacy. So that's one thing which you have to tell the patients. You and sometimes some patients, most of the patients will be on a indwelling catheter. So that's another problem in case of male or female. So as far as possible, we have to remove the catheter and make it plain intermittent catheterization. So that will help them to have some intimacy if they are uh, physically fit. Then so many patients might have erection even though they have spinal cord injury, but that erection may not be sustainable. That's another problem. And this erection may not occur at the time of sexual intercourse. Usually what I have read in literature is whenever the patient have erection, ask them to have a sexual intercourse. The wife should also be ready, and sometimes another problem would be the leakage of urine along with intercourse. So that might not be good, but this should be talked to the patient and his wife.
Okay.
Anything to add, Jijo?
Any most any most challenging things that you came across in the patient who are young patient, like if it is an adolescent male or female, any kind of a common problem, the most common challenging that that in palliative care, is there anything like that? Or
I think one of the common problem is they always ask whether they are going to improve. That's the most common question that they ask. And another few things are one is they some patients don't want the control of their parents or spouse. They want to be independent. They want to go from home and live somewhere else. So I don't know whether you have seen that. Some patients are like that.
Okay.
Jija was telling something. And I think, yeah.
Just adding that sexuality is a difficult topic to discuss with the patient. They usually they feel embarrassed about it, and usually the discussion does not progress much.
Okay. Actually, I conducted a study on 20 paraplegic patients regarding sexuality. And I found that all welcomed me because they want to talk regarding that. And they didn't had a chance to talk regarding this because nobody asked about it. And many of them actually told me what are the problems they face. And many patients after paraplegia or quadriplegia, what happens is they are on the probably lying on in a veranda or in a room where there is no privacy. So that's one problem that they told me. And the family thinks that after the patient become paraplegic, the intimacy is not needed. So they always welcome a discussion regarding sexuality. That's what I understood from my study. but maybe immediately after they become paraplegic, this may not be an issue for them, but after some time this will be an issue. Even both the husband and wife want to talk regarding this.
ఇది కంటిన్యూ నెట్వర్క్ కరెక్ట్.
Pankaj, are there anything more to add?
No.
No, no more.
Okay. So, Dr. Mong, Jijo, or Rebecca, anything you want to add? Or anybody else? So I think we can wind up this session. So thank you, Dr. Rebecca, for presenting this patient story. And I think one of the most important thing or challenging thing, as Dr. Moon asked, is talking about the sexual problems or sexuality is something challenging. But the most important problem they usually speak is about the ambulation status. Will they be able to recover from the present situation? And because of the physical problems, the loss of mobility, the independence, and there will be more psychological problems, social problems, and spiritual problems, as we saw in this patient. So it is important to empower the family members to take care of the patient. The physiotherapy, usually the patient's family call a physiotherapist to do the physiotherapy, and a poor family will not be able to afford a physiotherapist for long time. So it is important for them to understand what to do and how to do. So empowerment of the family is most important in case of long-term care. Uh, and telemedicine and things like that has to be explored, and it may not be possible all the time because the family member or the neighbor should have some smartphone. So that's the only problem. Otherwise, it can be done, which is effective also. The problem would be if they need some medicines or something, we have to drop it in their home, or we have to take the help of volunteers to take the medicine from the institution to the patient home, which we are doing currently. Okay. Thank you, Dr. Pankaj, and thank you all for participating. And before you leave, I request you to please do the feedback questionnaire. Please launch the feedback questionnaire. Yeah.
You can
Please
see a screen in the Zoom, so you can attend the questions there. Thank you all. We can see you next Friday with a session on gastrointestinal symptoms. Thank you and bye-bye.
Okay.